So good morning everybody. So now we're moving on to the next session. So next we have Dr. Rutul Gokulani. He'll be speaking on should all persons with diabetes be on statins. So very interesting topic. It's a yes or no. So this is always a debatable, actually it should be a debate. But he's the right person to do neutral things. Over to Dr. Rutul.
Thank you very much, Arvinda sir, for kind introduction, and thank you very much, Dr. A. Shanmugam and whole DAISI organizing committee for inviting me and giving me the chance to talk on such a wonderful topic, which is really crucial for this talk. So, should all persons with diabetes be on statin? Yes or no? I have both the sides, because I don't have anyone to debate here, but still I want to make some disclaimer that yes, we should ideally prescribe to most of our patients, because most of our patients are elderly age group and at least more than 40 years of age, and we know all the guidelines. So though it is nothing new, but what evidence say and why we should not prescribe and in which kind of patient we should avoid, that I'll be explained. So the debate question is, should all persons with diabetes be on statin? So good morning to V. Seshia sir. Hello sir. Yeah. So diabetes and cardiovascular disease as whole, if you see, so cardiovascular disease is the leading cause of diabetes in deaths in diabetic patients. So people with diabetes have 2 to 4 times higher risk of heart disease and stroke in comparison to non-diabetics. So chronic hyperglycemia is associated with metabolic factors, accelerated atherosclerosis in diabetes. So statins and diabetes, what should you know about it? That I'll be explaining in next few slides. So diabetic dyslipidemia and cardiovascular disease, these go hand in hand. We know that atherogenic dyslipidemia in diabetes it is associated with characteristic dyslipidemia elevated by triglyceride, low HDL, and of small dense LDL particles, even if LDL levels are normal. So this small dense LDL are highly atherogenic, and persistent lipid abnormalities occur in type 2 diabetes even with good glycemic control. So this atherogenic dyslipidemia is independent risk factor, where dyslipidemia alone plays a key role in driving cardiovascular disease in diabetes, and in fact dyslipidemia is a major independent predictor of cardiovascular disease in diabetic patients. So managing lipids is critical in diabetics to reduce cardiovascular complication. So why statin? We need to understand that substantial LDL cholesterol reduction and it modestly raise HDL and lower triglyceride, addressing the main modifiable risk factor in diabetic dyslipidemia. So this is the important modifiable risk factor. All other modifiable risk factor, we know, we call it modifiable risk factor, like for an example stress. Can we reduce the stress now in such conditions, such situations, what we are seeing in last 1 decade? So stress is almost it is now not a modifiable risk factor, but LDL cholesterol with medication can be modified. So evidence of benefit where both primary and secondary prevention in diabetes, where significant cardiovascular risk reduction is possible, and pleiotropic effect of this reduction of LDL cholesterol, they stabilize the atherogenic plaques and atherosclerotic plaques and reduce vascular inflammation as well as hsCRP, and it improves endothelial function as well. So visual evidence by European Society of Cardiology, what they said, that any time if you have elevated LDL or mixed kind of dyslipidemia, then you start with statin, then you may add ezetimibe or PCSK9 inhibitors or fenofibrate or bempedoic acid or any kind of other dyslipidemic agents. So guidelines, even ADA guideline and AHA guideline, they suggest that if age is between 40 to 75, then moderate intensity statin for primary prevention and high intensity if multiple risk factors are there in this age group. So you may directly start high intensity statin if patient has multiple risk factor, but at least moderate level of, so moderate level of rosuvastatin is between 20 to 40 milligram. So where age less than 40 and age more than 75, then consider statin if additional atherosclerotic cardiovascular risk factors or based on risk benefits, individualized decision should be there. And in any age with established cardiovascular disease, then high intensity statin is indicated for secondary prevention rather than in primary prevention, where we prefer moderate intensity. So diabetes is equivalent to coronary risk. So already patient has one cardiovascular event. This is what we consider in any kind of diabetic patient. So diabetes is often treated as coronary risk equivalent, where guidelines emphasize that baseline LDL level should not be sole factor, but the presence of diabetes itself confers high risk. Warning, statin therapy is in most of the cases. So the presence of diabetes itself considered equivalent to having existing coronary artery disease in terms of cardiovascular risk assessment. What RSSDI guidelines say? So what evidence and guidelines says that also RSSDI guidelines in 2022, they recommended that statins is the first line therapy for dyslipidemia in diabetic patients. So, and even one of the survey based opinion of Indian healthcare practitioners, which was published in 2023, and Dr. Sanjay Kalra et al. Published this, that pragmatic and early use of statin in patients with diabetes for prevention of atherosclerotic cardiovascular disease, which is accepted by almost all the healthcare professionals. So evidence from the most important trials are CARDS trial and HPS, that is heart protection study. So this CARDS trial was published in 2004, where atorvastatin 10 milligram used and it was compared to placebo for 4 years, and dramatic benefits was seen of 37% relative risk reduction for major cardiovascular events and 48% reduction in stroke. So this trial itself indicated that statin should be there on in every diabetic patient. This heart protection study, it was diabetic subgroup analysis, where HPS trial showed that, which included more than 5,000 diabetic patients, which used simvastatin, and 25 to 30% reduction in cardiovascular disease was found in this heart protection study diabetic subgroup. So other meta-analysis of CTT collaboration and pooled analysis of 14 randomized control trial, which showed that 21% cardiovascular event reduction and 13% mortality benefit in vascular mortality especially, and benefits were seen regardless of LDL level. So even if you have lower LDL, then meaning even normal LDL diabetic patients benefited from statin, and they had lesser cardiovascular events as well as stroke event. The most important trial till date is STENO2 trial, and this study design was done in Denmark, which was tested intensive multifactorial therapy in comparison to conventional care in type 2 diabetic patients with microalbuminuria, and intensive group received aggressive treatment of glucose, blood pressure, lipids and lifestyle. And this 8-year study's results showed that around 20% absolute risk reduction in major cardiovascular event, where number needed to treat was between 5 to 8 years, and long-term impact of this study showed that after 21 years of follow-up of those patients who were put in this Steno 2 trial showed that 7.9 years longer life in the patients who were treated aggressively in comparison to conventional treatment. So comprehensive risk control including statins yields dramatic durable benefit in diabetic patients, essentially adding years of life, healthy life. And Steno 2 trial highlighted that statin as a part of multifactorial management are crucial to improve survival in diabetes. So potential downside, now what could be the negative points where I would say that you may not use statin in all the patients, where maybe muscle related side effects, especially the most common adverse effects is myalgia, which is around 5 to 10% in most of the cases, but in clinical practice we have seen it may be around 10 to 15% as well in our patients, even 20%. But the critical complications like rhabdomyolysis are really rare. And liver and other effects, the mild elevation in liver enzyme with statin, and that we all know, but some patients report cognitive issue, memory fog, but controlled studies have not confirmed any significant long-term cognitive harm, and overall statins are very well tolerated and favorable safety profile is there. So statins and diabetes, we all know that statin-induced diabetes cases are reported everywhere. So new onset of diabetes, in meta-analysis it has shown around 9 to 12% relative increase in new onset of diabetes. In the patients who had already diabetes, we don't need to think much about it, because for patients who already have diabetes, and the diabetogenic effect is less relevant in those patients as they are already diagnosed, and we can control with the medication as already they are there on medications. So risk benefit analysis, so despite this slight rise in glucose, the cardiovascular benefit of statins far outweigh the diabetes risk, and this is why at the risk patients or multiple risk factor, who has multiple risk factor, in all those patients we should ideally prescribe statin even though they have diabetes, or even for primary prevention. So special cases and balancing consideration, elderly age group, this is very important thing, where if a patient with diabetes has aged more than 75 years or more, especially those with multiple comorbidities or the frail patients, one must weigh polypharmacy and potential side effects against benefits. So in most of the cases we should try to reduce the dose of statin if they have frailty issues and multiple comorbidities are there. So in type 1 diabetes, this is very important question, because nowadays we are seeing more and more type 1 diabetic cases with the age of 20, 30 and 40, and they have high LDL and high triglyceride levels, and they are also now overweight and obese if they have longer duration of type 1 diabetes. So what we should do in those patients, we have some clear guidelines. Some guidelines say that reasonable consideration should be there of statin in the age group between 20 to 40 in type 1 diabetes. So additional risk factors, if they are present, then you may add statin in this age group as well. Statin intolerance is one of the issue which we are seeing in our practice also. So a practical consideration is that a subset of patients simply cannot tolerate statins. So around 5 to 10% cases do not tolerate it well. For these individuals, forcing a statin and is if it is not feasible. So comprehensive review of statin intolerance and the practical application of bempedoic acid also should be made. So with this, I'll summarize that pros and cons of statin for all diabetics are there. So what are the pros? That substantial cardiovascular benefit is there. Around 30 to 40% benefit was shown in CARD study. Strong evidence base is there for CARDS, HPS and other meta-analysis. to show consistent benefit of statin in reducing LDL, and meaning broad use is justified. What guidelines? All the guidelines, most of the guidelines, they suggest if age is more than 40 years, and you should consider. But I feel that now, as diabetes in our country especially, it is getting at younger and younger age, then we may consider after age of 30 in type 2 diabetics, obese with multiple risk factors as well. So low cost and acceptability of statin is definitely there, especially in our country, very well tolerated. I would say around 5 to 10% have some myalgia, but it is very well tolerated. Cons, heterogeneity of risk. Some diabetic patients have much lower risk, and their absolute benefit from statin may be very small. So heterogeneity is definitely there. Over medication concern, so blanket prescription, prescribing statin in all patients, it may take a drug with minimal benefit to them and exposing them to side effects without clear need, and side effects and compliance. A subset will experience muscle aches and other side effects leading to non-compliance, and patient-centered care should always be there. So it may not be for all, but in most of our diabetic patients. With this, I'll conclude my talk. If you have any question, I'd like to address them. Thank you very much.
Thanks, Dr. Rutul. So the take-home message is statin should be all for all the diabetic patients. So in fact, when I was in UK during my training there, so one of my professors used to say that statins should be put into water tank. So much of pleiotropic benefit is there, that is there, way back in 15 years back. Still it holds the good. That is a wonderful session. We can take the question after these sessions as well. We have two more sessions.
Thank you.
Welcoming Dr. Sheshaya sir and Dr. Mohan sir. We'll move on to next session.
Good morning, everyone. I invite Dr. P. Dharmarajan for his session. The topic is triple combination therapy in diabetes, boon or pain.
Ladies and gentlemen, at the outset, I'd like to thank the organizing and the scientific committee of DAISICON2025 for giving me this opportunity to talk on this interesting topic. Again, this topic, triple combination therapy in diabetes, a boon or bane. Again, it's kind of a debate topic where, as the only speaker, I have to debate on both the sides and try to find a verdict. The plan of my talk over the next 15 minutes would be to give you an introduction to what is triple therapy, the triple combination therapy for diabetes, what exactly it is there any rationale of these combinations and the mechanism of action of these drugs, is there any clinical evidence, the benefit analysis, challenges and risks that are involved, and the various permutation combination of triple drugs that are available, and finally try to reason out if it is a boon or is it a bane and give a verdict. All of us know this background. We have more than 101 million people living with diabetes and more than 136 million people with pre-diabetes. And our Indian population of diabetes represents more than 14% of the global burden of diabetes and makes India epicenter of the disease. What is more important in this slide is the last one, where the current data shows that more than half of the patients with type 2 diabetes do not achieve their HbA1c target. So with this poor glycemic control, and diabetes, we all know, if left uncontrolled, can lead to all these attendant micro and macrovascular complications. This is where the use of combination therapy comes into play. Combination therapy with fixed drug combination is popular not only for diabetes, but for other disorders like tuberculosis, retroviral therapy, anti-cancer therapy, hypertension, bronchial asthma, etc., etc. Treatment of hyperglycemia, we all know, starts with monotherapy and then progresses to dual and triple therapy. That's the natural history of the course of the disease. Triple combination therapy is nowadays an established modality of therapy for type 2 diabetes when dual therapy fails to achieve targets. And in some cases, even during the start of treatment or the diagnosis of diabetes. What is this fixed drug combination? FDC, how do you define an FDC? A fixed drug combination is defined as combining two or more drugs in a single dosage form where each component contributes to the claimed effects, and the dosage of each component is such that the combination is safe and effective for a significant patient population requiring such concurrent therapy and defined in the labeling of the drug. What is the rationale of combining these drugs? The rationality depends upon one, the drugs in the combination, they should have different mechanism of action. Two, the pharmacokinetics should not be widely different from each other. And finally, the combination should not have any superadditive toxicity, thereby landing up the patient in problem. So with these rationale, we combine drugs, 2 drugs or 3 drug combinations. So the basic rationale behind combining 3 drugs is that it should target multiple pathophysiologic defects that initiate and perpetuate hyperglycemia in any patient with type 2 diabetes. We'll see about that in subsequent slides. And they should also have a synergistic effect for improved glycemic control. And these are the various combinations of triple drugs that are available in the market as of today. Combination of metformin with sulfonylurea and AGIs, combination of metformin with sulfonylurea TCD, sulfonylurea with DPP4 inhibitors, AGI with SGLT2 inhibitors, metformin with TCD and DPP4, metformin with GLP1 and SGLT2. And the most popular combination of all these is the metformin, DPP4 and the SGLT2 inhibitor combination, the triple therapy combination for diabetes, which addresses all the 3 basic pathophysiological abnormalities in type 2 diabetes. Metformin that takes care of the problems of the liver, DPP4 inhibitors in the pancreas and SGLT2 inhibitors in the kidney. So this is how this popular combination works. We know metformin decreases the hepatic glucose production, improves the insulin sensitivity and increases the glucose uptake. And DPP4 inhibitors act in a different way. They prevent the degradation of GLP1 and GIP, stimulate insulin release and decrease the hepatic glucose production. And SGLT2, they inhibit the renal glucose reabsorption, thereby not only in reducing the blood sugar, they also help in promoting weight loss and also help in cardiorenal protection. So all are additive effects that we see in this triple combination of diabetes. This is again to show how this triple combination is effective in the pathophysiological abnormality of the famous ominous octet put out by DeFronzo. Now, is there any clinical evidence in combining these drugs? Studies have shown that triple therapy achieves about 2 to 2.5% reduction in HbA1c when compared to dual therapy, where the reduction in HbA1c is about 1.5%. So a triple therapy combination is superior to dual therapy by a better HbA1c reduction, by achieving a better HbA1c reduction. Not only that, 70% of the people with on triple therapy, they achieve a HbA1c target of less than 7 when compared to 52% who are on dual therapy. So triple combination therapy is definitely beneficial when compared to dual therapy. And not only that, they also have a sustained glycemic control over a period of more than 12 months. And some combinations can also lead to a lower risk of hypoglycemia. So there is clinical evidence to show that triple drug combination scores over dual therapy or single drugs. What are the benefits of triple therapy? Apart from the superior glycemic control that is seen in these patients on triple therapy, there is also weight reduction benefits, especially when you combine the drugs with SGLT2 inhibitors, the GLP1 RAs, there is weight reduction benefits. There is a reduced risk of long-term complications. And the lower individual drug doses, the drug doses can be lower and they also help to improve the beta cell function and thereby leading to better patient outcomes. So there are definite benefits for this triple therapy. However, there can be challenges and risks. The treatment complexity is increased. There can be a higher risk of side effects, especially like hypoglycemia in certain combinations, gastrointestinal issues with certain combinations, especially if they have metformin and AGI combined together, weight gain in certain combinations, especially combinations which contain sulfonylureas. So all these could be problems. And greater financial burden, or triple drugs are little expensive when compared to the dual drugs. And there can be potential drug-drug interactions again. And if, because of the treatment cost, there can be a reduced patient adherence. And there is also a need for intensive monitoring when we put the patient on triple drugs at the same time. So these are the challenges and risks. So ultimately, which drug do we use? So there are several factors which we consider before choosing the patient, before putting the patient on a triple drug. Patient should have a high baseline HbA1c of more than 8.5 and failure to achieve with 2 drugs, absence of contraindications, and the patient should have a good compliance or good adherence to the current therapy. Then also we should switch them over to triple drug. And there should be an adequate healthcare support, and finally the patient should be affordable too. Now let us see some reasonings to say that triple drug combination therapy is a boon. Patients with type 2 diabetes have multiple comorbidities. So this increases the burden of medications. So this ultimate polypharmacy can increase the pill burden, resulting in poor compliance with the drugs. Even in countries which have high access to healthcare, studies have shown that good medication adherence is only less than 40%. So no wonder it is lesser in our country. Studies have shown, again, by 3 years, about half of the patients who are on dual therapy will require a third agent. They have to be switched out to triple therapy if you want to reduce the HbA1c to below 7. And studies have shown that if there is a 10% increase in good medication adherence, the HbA1c can be brought down by 1%, thereby translating into better prevention of complications. And this triple therapy also helps to cover the basic defects and the shortcomings of the ADA's stepwise theoretical treatment algorithm, which we have been following earlier. And then theoretically, FDCs can neutralize the potential side effects. For example, a weight gain which can be produced by TZDs or sulfonylureas can be neutralized by adding the weight losing properties of metformin. Metformin and voglibose, the increased GLP-1 secretion can have an additive effect. And then finally, some manufacturers, they produce code tablets even among the triple combination therapy, so the drug can be halved without any problem with the dosage precision. And finally, if 3 drugs are combined together, the cost of therapy can be lesser when compared to 3 drugs taken individually. So in that way, if you see it in that way, it could be a reduction in the cost of therapy in the longer run. So these are the reasonings to say that triple drug therapy could be a boon. Again, let us look at some reasons to say that this triple drug combination therapy could be a bane. There is a concern regarding the timing of administration of the triple drug fixed dose combinations, especially in relation to food, whether it should be given before food, along with food, or after food. Again, we always prefer to give the major drug which can produce problems with GI side effects, and then decide whether the drug should be given along with food or after food. The second point again, the trade names of certain FDCs may not give an indication to the underlying drugs or the components of the drug or dosage, so can produce some confusion to the prescriber. For example, sorry to mention the trade name, glynasemif, the sulfonylurea in glynasemif is glipizide, whereas the sulfonylurea in triglycinase is glimepiride. So we need to make ourselves aware of these things, otherwise we'll be put into trouble. In a triple fixed dose combination, 2 drugs may be acceptable, but the third drug may be contraindicated. For example, an FDC of glimepiride, metformin, and pioglitazone may be working well till the patient has a stable heart failure. But if the patient has a worsening of heart failure into class 3, pioglitazone becomes contraindicated, metformin may have to be withdrawn. So in the event of this suspected adverse reaction, if you want to withdraw a single drug, you cannot do that, and you have to withdraw all the 3 drugs, and the whole medication has to be replaced. So, and again, the ceiling dose of this in the triple drug combination, the maximum tolerated dose of one component of a fixed dose combination may be different from that of another. The potential for dose titration may be limited with triple FDCs. So sometimes we may be forced to add another drug that can increase the pill burden. So these are some of the reasonings to say that triple drug combination therapy could be a bane. We all are familiar with the indications for the triple therapy, where we use the triple therapy following failure of dual therapy, or in patients where the A1C is more than 9, you can straight away start with triple therapy if the patient is asymptomatic. Again, what about the real world evidence? We have seen studies showing beneficial effects of triple combination therapy, but the real world evidence also shows that triple therapy has a better target achievement when compared to other dual therapy or single drugs. There is significant improvement of the beta cell function, lower hypoglycemia rates, better durability of glycemic control, and positive cardiovascular outcome in selected patients. So even in real world evidence, these drugs, triple drug combination has shown beneficial effects. And future perspectives also show that fixed dose triple combinations have shown to improve the adherence. And if you look at personalized medicine approaches or more of precision medicine, triple drugs will be helpful. Novel drug combinations are under investigation. Digital health integration for monitoring is needed. And finally, cost-effective improvement is expected. These are expected in future. So, to conclude whether it is a boon or bane, triple drug combination therapy can be a boon if the patients are selected appropriately or properly, appropriate drug combinations are selected along with adequate monitoring and support. And the same triple drug combination therapy could be a bane if appropriate patient selection is not followed, and if there is a poor adherence or if there is poor monitoring or in the presence of if the patient is not affordable leading to poor compliance. So overall it is a powerful tool requiring judicious use in patients with type 2 diabetes. So finally to summarize, if used wisely, triple drug FDCs provide effective glycemic control in a safe, well-tolerated and economic manner. So we as physicians and other healthcare providers should take the effort to educate ourselves and others about the proper content and dose of the various FDCs if we want to avoid the potential prescribing errors. Combination therapy with FDCs early in the course of the disease may be required and is advisable. So finally, I'd like to conclude saying triple drug combination therapy could be a boon in the therapeutic armamentarium of type 2 diabetes. These are my references, and finally I would like to end with one of my favorite slides by Professor Hariharan, who says, if a patient is already under good control on an oral drug under another physician, please do not change it just because he has consulted you. For you may find to your dismay, he does not respond to any other drug the same way, forcing you to use the same drug that you advised him to stop, provided of course the patient is still with you. So this is a very important learning point or practicing point that we should learn by Professor Hariharan. Thank you all for your patient hearing.
Thank you very much, sir. This is a very interesting topic, well discussed and concluded very well. Thank you so much, sir. We look forward to the discussion.
So we'll move on to the next session. We can take the question and answer session at the end of this particular session. So next topic is by Dr. S.S. Lakshmanan, sir. The topic is decoding the heart-kidney axis in DKD, a comprehensive clinical approach. Over to you, sir.
My slides, please. I thank the organizers for this topic given to me. I'll today update some of the important management aspects of the diabetic kidney disease. I'll also tell you how quickly you can bring the albuminuria and how effective it is. I'll also tell you on finerenone, some of the latest indications and the clinical trial program and the safety and the how to start in your clinical practice. A crowded slide which says that compared with the healthy individuals having a CKD and diabetes, shorten life expectancy by 16 years. Kidney failure occurs 10 times more in a diabetic than a non-diabetic. CKD and diabetes mellitus increases CV mortality by many times. Most probably about 60 to 80% of exit door of type 2 diabetics is through the heart. As you could see, a nice slide where the CKD and type 2 DM are increased risk of death from CV-related causes. You could see the presence of CKD in a type 2 DM increases the CV-related death by 6 times. A person with 3.4%, a normal person to 19.6 when a person has got a CKD and type 2 DM. I think it's really alarming. And the late diagnosis and CKD progression in patients with type 2 DM burden both the patient and the healthcare systems. Look at this data. CKD and type 2 DM combinations increases myocardial infarction 2 times, heart failure 5 times, CV deaths by 3 times, and dialysis up to 40 times more in the normal person. I think that's a very, very sad situation. And early intervention, if you could do that in a CKD patient, help to reduce the downstream cardiorenal risk. Assessment of both albuminuria and EGFR is required. I think for the youngsters, you should know the definition of the diabetic kidney disease. When I ask in the rounds, the students do not answer this question. The definition is that CKD and diabetes is defined as EGFR less than 60 ml and or you can have either albuminuria or EGFR or can have both. Albuminuria more than 30 milligrams. That's a slide tells you that we should check the patients both EGFR and the albumin. Look at the slide here. The typical CKD patient, if you put the KDIGO guidelines plot, if you only measure the EGFR alone, the patient has a very, very low risk. But when the same patient, if you really put at the patient's plot or the albuminuria, the severity increase to high risk. So assess the severity of CKD in a diabetic by using both the USCR estimation and the EGFR, not by only EGFR. Look at the mortality rate here, the 30 milligrams, the mortality starts. See, increasing USCR's risk factor for CV death, even all-cause mortality, even at a lower value of 30 milligrams. At very, very early predictor not only of the kidney disease progression, but also worst CV outcomes, even at a very low value of 30 milligrams. Beautiful slide. I tell you, this slide gives you a meta-analysis of clinical trials suggests that even a 30% reduction of albuminuria, 30%, you need not reduce all 100%, reduces risk of CKD progression. Even by 30%, we can reduce the CKD progression and composite kidney and cardiovascular outcome by 27%. That's more important. How rapidly you could bring down the albumin to 30%. I think the slide is going to tell you more. Look at the guidelines. Now recommend both checking of EGFR and UACR yearly once, all the ADA, KDIGO and the AAC guidelines. So all type 2 diabetic patients should undergo yearly testing of these two tests. Could MR overactivation serve as a potential treatment target to slow the progression of DKD? Yes. Because we have the factors which really promotes kidney and heart failure, the hemodynamic factors and the metabolic factors and the MR overactivation. We know the hemodynamic factors can be treated by your ARBS, AAC inhibitors, metabolic factors by good drugs like SGLT inhibitors, GLP-1s, metformin. Of course, the inflammation and fibrosis are the new one, which are drivers of the CKD and CVD progression type 2 DM. And the inflammation and fibrosis by targeting the MR overactivation by phenylenone. So combined effect of RAS blockade and good correction of the blood sugar by the SGLT2 and GLP-1 and metformin, and also by addition of the phenylenone helps your patients to get rid of the complications and done away with that. Phenylenone primarily blocks the MR overactivation and slowing the kidney and CV disease progression. And MR overactivation blockage of phenylenone slowed both the CKD and heart failure progression. Look at the available three molecules of the MR antagonist, the spironolactone, which is mostly used in resistant hypertension and in the cirrhosis liver with the ascites, eplerenone mostly in heart failure, HFrEF. And now the new molecule, phenylenone. How is it different from these two? The phenylenone is a highly selective and highly potent, short-acting MRA without steroidal side effects like gynecomastia. It has got a greater proteinuria reduction, lower rates of hyperkalemia, and currently approved only in CKD with type 2 DM, not in non-diabetic chronic kidney disease. Look at the slide which tells you the trial with ARTS compared 389 patients, the HFrEF and CKD with the spironolactone and the phenylenone. Worsening kidney failure and the hyperkalemia occurred less frequently in all groups of patients receiving phenylenone compared with the spironolactone. So again tells this drug is much, much safer when compared to the spironolactone. What evidences support the phenylene's cardiorenal benefits? Now we have the well-known trials, the Fidelido and the Figaro DKD and the Fidelity. The Figaro DKD looked at the time to kidney failure. The Fidelio DKD looked at the time to CV death. And the pooled analysis of Fidelity looked at both time to CV death and kidney failure. I think largest study, I think we have 13,171 patients and duration of 3 years. Look at the benefit of the molecule. Look at the left-hand side. They are all very, very, very well controlled. All the patients have a very good control of A1C, nearly 7.1. BP is 137/76. More patients are on SGLT2, GLP-1, statins, 100% RAS blockade, 99.8. So the population is a very, very well controlled population with many drugs. Over and above this population, we added phenylenone, the benefit was there. That's the beauty of this trial. I tell you, the trials are done in albuminuric diabetic kidney disease patients. And the phenylenone reduction, the 32% between the baseline and month 4. Look at the slide says that by 4th month, you get the guideline required, the 30% or 32% of the USA reduction by 4th month. But can you still bring it faster? Can you still bring it much more before 4th month? It is possible. It is definitely possible. Now the phenylenone improved the cardiovascular and the heart failure outcomes both by 22% and 32%. And the ESC 2023 has said the drug has to be given for heart failure prevention recommendation, not heart failure treatment. Now look at the slide again, tells you, I think, number of the nephro friends always say, the drug also causes hyperkalemia. See, the study population is about 13,171 patients. The dropout rate is about only 110 patients. It's almost 1.7%. But you could still bring it down. Can you bring these complications of slight hyperkalemia, which happens with the phenylenone, because there is no hyperkalemia leading to death in this study? Can we prevent this less hyperkalemia caused by phenylenone? Yes, and how? I think this is a beautiful latest evidence, the unlocking the power of combination of use both phenylenone and SGLT2 in a cardiorenal protection. Confidence study is the one which really investigates to look at the efficacy and safety of the simultaneously initiation of phenylenone and SGLT in CKD with the type 2 DM. They had 3 arms, one arm phenylenone, one arm phenylenone plus the placebo, one arm empagliflozin, other arm EMPA plus the phenylenone. The conference trial, the name came from a combination effect of phenylenone and the empagliflozin in participants with the CKD and type 2 DM, evaluated the combined effectiveness of safety of phenylenone, empagliflozin in patients with chronic kidney disease and type 2 DM. Look at the patient population, very, very high risk, high comorbidity population. See, all of them, the male and female is 3:1, age is 66.5, obese people, BMI is average 29, mean EGFR is 54, median USCR is 579 milligrams, A1C is 1.3, serum potassium is 4.5, hypertension, all had hypertension, 88%, ASCVD 28%, retinopathy 16%, almost 100% are on ROS blockade, either AC or ARBS. GLP-1 almost 3%. 133 patients also from India. That's the high profile group of high risk population, but well controlled of their blood pressure and the beautiful slide. When you initiate simultaneous initiation of phenylenone and SGLT, lead to the reduction of UACR 30% at day 4. Day 4, not like 4th month when you use only phenylenone. See, by day 4, it come to 30% reduction. By day 30, there's a 35% reduction of the albuminuria. By day 90, there's a 49% reduction of the albuminuria. And by day 180, almost 52% had come to the level of reduction of the albuminuria. So again, it tells you that when you add these combinations, the albuminuria reduction is faster and greater. Almost, I think, 70% of the people have achieved the target of the reducing the albuminuria by 30%. So when you initiate the phenylenone and SGLT inhibitors associated with a reversible reduction in the systolic blood pressure and initial GFR decline, however, was not associated with serious kidney-related adverse events. There is some eGFR comes down, but it gets back to normal and sustained with that. So there's no need to worry about this particular eGFR decline. Now look at the complications of hyperkalemia. It is almost much smaller in the combination group. When you combine with each group, phenylenone, empagliflozin, and when you combine with the combinations, the combination of phenylenone with empagliflozin lower the incidence of hyperkalemia by their synergistic action. Why hyperkalemia is less with the combination of phenylenone with empagliflozin? Phenylenone increases potassium due to aldosterone blockade, but empagliflozin decreases potassium levels by natriuresis, osmotic diuresis, distal sodium delivery that handles the sodium in the NAC receptors, in the DCT, and the kaliuresis. Kaliuresis is a beneficial excretion of the potassium. Combination of these two drugs balances each other, leading to reduced hyperkalemia risk with excellent renal and CV protection. I think now the fear is gone that the drug causes hyperkalemia. All my nephro friends says, no, I will not use phenylenone. We see very hardly nephrologists using the phenylenone for fear of hyperkalemia. I think now the news is that when you use it along with the empagliflozin, the hyperkalemia risk is much less. So conference summary is that there's a very early reduction of UACR of 30% by day 14. 70% of the patients achieve the ADA recommended target of 30% more than that UACR reduction. And overall adverse event profile for the combination was similar to that of either agent. What else you require? I think we've been using now this combination to a very greater extent. I think the benefit can be shared to your patients who have albuminuria. Can you use phenylenedione in heart failure? Answer from the floor. It is approved. So fine arts heart failure study in HFF in patients with heart failure with a mild reduced or preserved ejection fraction. Phenylenedione resulted in a significantly lower rate of composite total worsening of heart failure events and death from cardiovascular causes. The fine arts HF study. The fine arts HF study, not all are diabetics. Not all are diabetics. 40.7 are diabetics and some are pre-diabetics. So almost 20.8 were normoglycemic patients, normoglycemic. So patients both HFmef and HFF are benefited by the phenylenedione in diabetics and also in non-diabetics. There's a message to the cardiologist. The FDA has approved this combination of heart failure with the preserved ejection fraction with the phenylenedione, but not yet approved by India. So now we have the 4 drugs which is approved for the FF, empagliflozin, dapagliflozin, sacubitril/valsartan and the phenylenedione. And quite possibly very soon we will also get the indications for semaglutide and the tirzepatide. Practice, you always start with the 10 milligrams, the eGFR is less than 60, more than 60 you always start with the 20 milligrams. The baseline is look at the potassium, it should be less than 5. We can escalate the dose if the potassium remains constant less than 4.8 to 20. 4.8 to 5.5, don't increase the dose. More than 5.5, stop the dose. All the guidelines now recommend the phenylenedione in the diabetic kidney disease treatment. And the take-home points are very clear. Albuminuria is very predictive of CV and kidney endpoints. Reduce the albuminuria. Try to reduce the albuminuria much faster. In-stage CKD management is often missed. Despite RAS blockade and SGLT inhibitions, patients are at risk of CKD progression. And phenylenedione demonstrates efficacy in slowing the CKD progression and preventing CV events across all CKD stages. Now recommended with along other medications for CV and kidney protection. We can reduce 30% of albuminuria by day 14, confidence trial. New indications in heart failure with the HFmef and the HFF by the fine arts of trial. Thank you for the patient listening. Thank you.
Thank you, sir, for the wonderful deliberation. Very interesting topic and interesting input. Now we have 10 minutes for discussion for this session. I request Dr. Rutul, Dr. Dharmajan sir, Dr. Lakshmanan sir to be on dais. The floor is open for discussion. We can have questions, please.
Sir, wonderful discussion by all the experts. Really learnt a lot, updated informations. Sir, Lakshmanan sir, there is a thing, there is a overexpression of the RAS system, renin angiotensin system, and overexpression of SGLT system in the diabetes. To prevent kidney disease, can we start RAS inhibitor and SGLT inhibitor right from the diabetes onset so that we can prevent the kidney disease in future?
Yes, in fact, the fidelity pool says all 100% are albuminuric CKD patients. They are all put on phenylenedione, and some of the patients also on SGLT inhibitors. The benefit is seen over and above RAS blockade and SGLT inhibitors.
Oh,
We can definitely start.
yes, thank you, sir. Thank you.
It's a nice exposition of all the topics by the 3 speakers, sir. The first speaker I would like to ask, sir, regarding statins. There is a lot of hue and cry from other parts of our own department, the other allied departments, saying that statins produce diabetes. My question is, what dose of statins will produce diabetes? Number 1. Number 2, is it that all patients who are put on statins are going to for diabetes, or is there any genetic predisposition that patient may go in for diabetes?
So, very relevant and very good question, sir. So, the first thing, what is the dose which causes hyperglycemia? It is clearly stated in most of the trials that it is high intensity only and it even increase 0.2 to 0.4% of HbA1c, so very mild kind of hyperglycemia is due to statin, and in already known diabetic patient, even we don't come to know in most of the cases whether it is due to statin or something. So except clinical trials. So this is what the answer is.
So regarding diabetes, the day I diagnose, let us say 25 plus, am I right in starting the patient statin, sir? No comorbidities. His only HbA1c is raised. He's thin built, BMI is okay. No dyslipidemia, no hypertension, no obesity. For the pleiotropic benefits, can I start?
Sir, in my slides also I showed, if your age is more than 75, but we can even consider 72, 73, and if no comorbidities, no dyslipidemia, then I feel that no need for statin in those frail patients.
No, sir, no. My question is 25.
25?
Yes.
Okay,
yes.
I thought 75, sorry. So in 25 years old, definitely no need, definitely lifestyle modifications come before that, and it depends on the patient profile, as you rightly said, that no dyslipidemia, no comorbidities, then definitely no need to start statin. After age of 40, it is
Why, sir? Why?
Clearly it is in
No,
guidelines.
my question is very simple. Why? You are showed any number of points on the pleiotropic benefits. So why not I start? I don't know which point of time, whether it's midday or morning, afternoon, night, he is going to for a complication.
So
No, my question is very simple. Why not I start? If I start, what is the drawback?
So-
What is the great disadvantage I'm going to face with the patient?
So the duration of diabetes is the most important thing when
Sir,
you
I
get.
told you 25, sir, just beginning.
This is what I'm telling you, sir, that this is duration of diabetes which matters the most. And then you start the statin. In most of the cases when age is more than 40 or 45, and those cases have longer duration of diabetes, you are going to get benefit. If you see the risk-benefit ratio, at 25 years of age, you are not going to have more benefit than have more risk with statin.
Suppose if I say that's one or two problems, so that he has a little bit mild obese, BMI is a little bit okay. At 27 years, we see a lot of patients with a 25, 27, 28 BMI. Hip waist ratio is high and mild dyslipidemia. Can I start?
Sorry, I could not get it exactly. I could not even understand.
So below 40 years, the patient has even one risk we can start statins, even the new patients. Family risk, obesity, they have smoking, the sedentary lifestyle we can start. Otherwise, above 40, all the patients, below 75, we will start statins. I think
Sir,
Yeah, that's
my
a good conclusion, sir. That what you said is the very appropriate and a very clear message is there.
So
Dr.
my-
Dharmarajan, sir, one question is there regarding FDC. It's always nice to have triple drug combination. It will be user friendly and pill burden is reduced. Economy plays an important role. But when it comes to dose titration, it is always a challenge.
Yes, exactly. That's what I said, I enumerated in the Bain section, but dose titration is very, very difficult when you use triple drugs. In fact, though I projected so many things and I argued and said it's a boom, I'm not a very big prescriber of triple drug combinations, primarily because of this practical issue of difficulty in dose titration, especially when you want to up titrate or down titrate. Again, you'll have to break the whole combination and then go for a whole set of new drugs. The patient thinks the whole prescription is altered. And then again, many times we find that the patient already has the drugs, 1 month drug left with him. He doesn't want to waste the drug. So we'll be forced to use the drug and then change once the drugs are depleted. So there are so many practical issues.
Especially if the patient has got different stages of CKD.
Yes,
Is,
exactly.
Which to uptitrate, the dose reduction has to be done. Here 1000 milligram of metformin
Yes,
is already
exactly.
there. Sitagliptin 100 is there. We have to down titrate that.
Exactly.
It's always a big challenge.
The same
But
issue
selecting the appropriate patient should be an important aspect.
That happens even with dual therapy. With triple therapy, it's even more when we use FDC. FDC is very useful only for patients who are under stable control for a long period of time. For better compliance and better economical reasons, you can switch over to FDCs of triple drug combinations.
Sir, my patients are 70 plus, 80 plus. Some of my patients are 90 plus. I started this patient about 35 years ago with a statin, all these things. Now the patient's going older and older. So can I put these statins, low dose statins on alternate days?
The tolerable dose they can take.
Yes, that's what. So regarding the fixed drug combinations, we have to study clearly the label on it, sir. Suboptimal dose, DAPA 5, SITA 50. Where does it stand? So the doctor who is taking up a prescription, writing a prescription, he should go through the label, what it is, then he will think about it.
So exactly, that's what I also projected, said that we have to be familiar with what are all the triple drug combinations that are available, the dose that is prescribed, and we should be familiar, we should educate the patient also. Patients are co-practitioners also regarding the availability of these drugs. Many drugs are available like that.
So regarding albuminuria, it is better not to look you only to the albuminuria, sir, because stress, fever, infections, there will be mildly raised in albuminuria. But the best predictor is UACR. So that is one thing which you have to look into all the people, because I see some of the lab reports only mentioning about albuminuria, and we should not take that into cognizance. And another thing is, I have seen patients with non-diabetic kidney disease with IgA nephropathy, wherein the albumin is 2.7 grams, and after 6 months of giving this finerenone, it has dropped down to 100. So, in spite of a wonderful molecule for diabetes kidney, it is also a wonderful molecule in non-diabetic kidney disease also, sir.
Thank you so much, sir. The remaining,
I think the last question. I think for non-diabetic kidney disease, the approval has to come, number one. The trial is going on, fine CKD. Probably once we get the trial results out, we'll be starting the patients. And as he rightly said, even the USCR should not be done during stress, during fever, during severe hyperglycemia, during menstrual cycle. We have to really check 2 times before you confirm that the patient has albuminuria even by USCR.
thank you so much, sir. Thank you, all the speakers and the
Thank you, sir.
for
Thank
the
you.
interaction. The remaining questions we will have over the coffee break. Thank you.